Hey, Happy New Year, everyone. Thanks for showing up for our Facebook Live. I'm here at Regenexx headquarters in Broomfield, Colorado with Chief Medical Officer Dr. Chris Centeno. Today we want to talk about PRP versus total knee replacements. So it sounds like an interesting topic. I'm interested in learning more about this as well. So I'm going to turn this over to you and we can get started here.
Yeah, Happy New Year. This topic kind of came up because, I do a lot of work on LinkedIn, and we had some surgeons that we were going back and forth with who were doing knee replacement. And what's really interesting is that you would think that since we've been doing knee replacement for a long time, decades, that we would have lots and lots of high-level research that shows that knee replacement is really effective. Interestingly, we don't. We actually have only two high-level studies that are called randomized controlled trials, and neither one of those used a placebo control, which is really common in research. And when they used a physical therapy control, what they found was that the knee replacement wasn't all that effective. 3 and 4 of the patients ended up getting better with physical therapy after a year and never had their knee replacement. And the ones that did, you need to amputate 6 knee joints to get one patient who reported more than 15% functional improvement. Generally, other studies have shown that if you replace grandma's knee who can no longer walk the mall because her knee hurts too much, that those patients do pretty well. But if you replace a 45-year-old's knee who wants to continue to ride his bike 100 miles a week, those patients aren't as satisfied. So that's probably why we're seeing those results. Having said that, platelet-rich plasma has about 20 randomized controlled trials published on it at this point that show it's effective for knee osteoarthritis. Everything from testing against steroid injections, testing against placebo saline injections, testing against exercise, against hyaluronic acid, etc. So there's this interesting perception out there that we have more evidence showing that knee replacement is effective and much less evidence showing that platelet-rich plasma is effective, when in fact the truth is actually the opposite. We have very little evidence that knee osteoarthritis is effective. And we've got a huge amount of evidence that PRP is effective for knee arthritis. So it's just an interesting topic. It's the reverse of what you would believe in talking to the surgeons.
Yeah, that's interesting. And we're seeing total knee replacements being offered to younger and younger audiences nowadays.
We are. And in fact, that's one of the biggest problems I think out there, in that, again, the studies seem to show that if you're replacing grandma's knee because she can't walk the mall because she's got too much knee pain, grandma does pretty well. But when it comes to the 45-year-old athlete in general who expects to do lots of things with their knee replacement, they're not doing as well. Their reported satisfaction is much, much less. So now, why are we replacing all these younger knees? Because if you're a knee replacement prosthesis company, the only way you can really expand your market share, you can't invent more knees. All you can do is to go younger, and that's what they've done.
And about how long does a knee replacement last?
Yeah, that's highly dependent on activity. So again, if you're replacing grandma's knee who just wants to walk around the mall, you can get 20 years plus out of a knee. If you're trying to replace an athlete's knee who really wants to get out there and hit hard, you might only get 8 to 10 years. So big difference between those two patient populations.
Right, yeah. And I know you've done some cost analysis with knee joint replacement versus some of the orthobiologics. What's the price differential on some of these?
Yeah, so even when if we use the results from the randomized controlled trial that we published, on knee osteoarthritis using bone marrow concentrate, which is a same-day bone marrow stem cell procedure for the knee, and we even factor in cost for knee replacement on our patients who failed, we're still coming in at around about a 44% cost savings over knee replacement. These procedures not only can be effective, but they can be cost effective as well.
Yeah, that's great. Hey, Walls has a question. Do your stem cells age as you do?
They do, but interestingly, the number of stem cells stays pretty constant. So we've actually done the world's largest look at this with 99 patients, and we didn't see a difference in the number of stem cells in your bone marrow as the patient ages. When you see doctors talking about that, they're adding in the spectrum from being a neonate to a 5-year-old to a 10-year-old to a 15-year-old to an adult to a 50-year-old to a 70-year-old. But when you just look at adults, it doesn't change very much over our lifetimes. What does change is how quick those cells can grow in culture.
Interesting, because you hear that a lot.
Yeah.
Linda asks if we will offer Prolozone, and if you can explain a little what Prolozone is, that'd be great.
Yeah, so Prolozone is a combination of Prolotherapy to which ozone is added. So ozone instead of O2 is O3. No, we've never used Prolozone primarily because there are no FDA-approved medical ozone generators in existence. All of the generators being used out there are not FDA approved for use in the United States. So we've not wanted to get into using devices that are not FDA approved. Now, generally, it seems like there's lax enforcement there. So I've only heard of a few providers getting the machines removed from their offices. But realize that these are not generally medical grade devices that have been approved in the United States. They're either imported in from another country where they have an approval, or they're just industrial grade. So we don't want to get involved in the middle of that.
Hey, we're not going to go anywhere. I'm going to wipe off this camera lens because it looks a little blurry. Hopefully that helps. What's the whole theory behind Prolozone? Just the extra oxygen, supposedly?
Yeah, that's the theory. The extra oxygen would be how it works. Obviously, Prolotherapy works through causing an inflammatory response. That kind of gives you another bite at the healing apple. But the extra oxygen is supposed to help ramp that up. As to whether Prolozone works better than Prolotherapy, I don't know of any study testing them head-to-head. We do use a lot of Prolotherapy. We have for many years. But I don't know of a study that's tested Prolozone head-to-head with Prolotherapy that's out there.
There's probably a lot of people out there that have a question maybe similar to Julianne's. Can you add PRP or stem cells to a total knee arthroplasty or joint knee replacement after the fact to make it stronger?
Yeah, I don't think it's going to make it stronger. We have done some patients where they've had prosthesis loosening or tried to do that, and that means that the prosthesis isn't bonding to the bone. And what we've what we've generally seen there is that that doesn't really work well, probably because the prosthesis loosening is happening because the body is reacting to the metal or some component of the prosthesis, and putting stem cells there just means that the body reacts, the stem cells react to the prosthesis as well. So we haven't seen a lot of reason to do that. Now, you could be in a situation where you still have knee pain after a knee replacement, and that might be from structures that weren't replaced, so we can treat those, or it might be from referred pain from your back, so we can treat that.
Carl asks, how does PRP help if it doesn't have stem cells in it?
Yeah, so a good way to think of PRP and stem cells is a construction site. So PRP would be like we go out and we buy, 10 espresso shots for each construction worker, and we feed them an espresso shot once every hour for the 10 hours that they're working. More work is going to get done, and that's how PRP works. It stimulates the local repair cells to do more work. Then you've got stem cells. So stem cells would be like hiring a general contractor to supervise all of these workers and or bring in more workers that might be necessary to do the job. And then at the end of the day, the general contractor can also turn into the bricks and mortar. So those are the differences between the two. But realize in our practice, about 80% of the time, PRP will get it done. Only about 20% of the time do we use stem cells. And I always tell patients, it's my job as your physician to choose the least invasive, least expensive thing that's the most likely to work. And many times that's PRP. Sometimes it's stem cells. But realize that the first thing you can identify in a clinic that doesn't have a clue what it's doing in this area is if all they offer is stem cells. That is completely inappropriate. That's basically price gouging the patient for no reason other than you want to maximize your profit and don't really care about the patient's pocketbook. So if you see a clinic that's just out there offering stem cells, I would run, because there's no rationale for it. When 80% of the time or 70% of the time, a less expensive therapy will get the same results.
Well, that's good information. I've seen people getting a partial knee replacement. That's just like one side done.
Yeah.
And then what happens, what's next? I mean, do they go on to something else?
Yeah, I mean, it just depends whether or not the other parts of the knee get arthritis. But at the end of the day, realize that we have treated some of those patients with stem cells where they've had pain due to the other side of the knee, and they've done pretty well. So those are our patients that we can treat when they've got those partial knee replacements.
Let's see. Johnny states that he had an intradiscal injection. Soreness is gone. Doctor said that if it works, he should start to notice a difference in 1 to 2 months. Is this correct?
Yeah, with intradiscal PRP or bone marrow concentrate, you should see improvements kind of in the 1 to 2 month range. So I think that's pretty reasonable to say. Just realize that we have a lot of doctors out there that are just injecting discs because that's what they know how to do. What we found is that's not so successful other than in a pretty limited group of patients where it can be very successful. So realize that if you take 100 patients with back pain, probably 10 or 20 of them would be candidates for an intradiscal injection. About 80 to 90 would not. So, but we see doctors, routinely injecting discs for back pain. So be a little careful there. You've got to be the right type of patient to get that type of injection.
Look, I want to ask if you know a family member, a friend, someone you work with who may be looking at orthopedic surgery or is suffering with musculoskeletal pain. If you would mind, go ahead and share this with them so that they can find out that maybe there's other things available for them. They can put off surgery or at least get another opinion and make sure that surgery is not the only option for them. Just go ahead and share this with them. Stacy asked, if you use PRP and it doesn't help, can you use stem cells or is it one or the other?
No, it's a good question. We commonly see patients where we will use PRP and for whatever reason it fails, and then we'll go on to using stem cells. So no, if anything, one probably makes the ground, if you will, a little bit more fertile for the seeds.
Right. Now, I mean, is it pretty accurate that like once you get into a joint, maybe ACL repair or a knee meniscus repair, that it's going to accelerate the degenerative process towards a knee replacement faster?
Yeah, so there's an interesting study done by a guy out of Harvard, and what he was able to show was that when you go in and get an ACL tear, for instance, in your knee, that's one hit to the cartilage, and you can measure that hit to the cartilage by measuring a marker called CTX2. So the CTX2 levels go up because you get a hit to the cartilage after your injury. Now what was really interesting was that the second hit to the cartilage happened after the ACL surgery. So the ACL surgery itself caused another hit to the cartilage. So that could be one of the reasons why we see ACL surgeries, even though they stabilize the knee, these patients still get osteoarthritis, and there's no difference at all in the amount of osteoarthritis you get despite the knee being more stable. And it's probably because the surgery causes a second hit to the cartilage all by itself.
Carol asks, can one have a stem cell therapy if on blood thinners?
Yeah, Carol, generally what we will do is to try to take the patient off of their blood thinners for a short period of time. Or if that's not possible, then just put them on subcutaneous heparin shots and then take them off for just a very, very short period of time. But usually it's feasible to take them off for a couple days and then they go right back on right after the stem cell procedure.
So similar question to the ACL. I saw a ex-University of Iowa football player who had knee meniscus surgery in college, and now he's in his early 40s being told he needs a joint replacement. Same wearing out of the joint with meniscus surgery?
Yeah, I mean, we see the same thing. So there's now at least one published study that carefully looked at patients who had knee meniscus surgery versus patients who had tears who never had surgery. And the patients, again, who had surgery ended up having more arthritis down the road than those who never did have the surgery. So there's this sense by surgeons that you need to go in and clean up the dirty room. You got to take out the tear. The tear is causing all sorts of problems. In fact, the data would suggest the opposite, that leaving the tear there is actually better than taking it out. And it's probably because not only are you giving a second hit to the cartilage, like I just described, by doing this surgery, but you're also creating a problem where you don't have as much cushioning for the knee joint because you're taking out parts of the meniscus.
Great news, Juanita. She shares PRP at Regenexx worked amazing for me. Now I'm training for the final Olympic rugby qualifier.
Oh, great. Congratulations and good luck on that. Let us know what happens.
Yeah. Kelly asks, which is better for ligament instability, Prolotherapy or PRP?
Yeah, I mean, for a lot of ligament work, if the ligament has mild laxity, Prolotherapy works really well. It's inexpensive, and so we'll use that quite a bit. If we compare Prolotherapy to PRP results, we tend to see better results with PRP, meaning that if someone might need 2 or 3 injections with Prolotherapy, you can usually get it done in 1 or 2 injections with PRP. So there is some advantage to using PRP, but Prolotherapy works really well for loose ligaments that aren't that disrupted. Now, if you've got a ligament that's more disrupted, then it's PRP, and if it's really bad, that's more bone marrow concentrate.
Maybe you can explain a little of this. I had a friend who had an osteochondral defect who went and had surgery, and it took forever for her to get better and still having pain. Is that something PRP or stem cells could help?
Yeah, probably more stem cells in that case of having an osteochondral defect, but yeah, I mean, you know, the problem is there's really no great way to fix an osteochondral defect. All of the surgeries that you would look at, microfracture, Oates procedure, ACI, MACI, they're all not perfect. They all carry certain risks. They all don't produce perfect cartilage in there. So there's really no elegant solution to that problem at this moment.
What are your thoughts on, you see athletes get MCL, medial collateral ligament sprains, and just keep playing on it? You think that's causing damage?
Yeah, we see a lot of people out there who have problems with, laxity, and they don't even know it. So especially the younger you are, there's a lot of athletes out there playing on unstable knees and ankles and shoulders. They don't really know that it's unstable. They go to their orthopedic surgeon who's looking at it simply from the standpoint of, is it unstable enough for me to want to do a surgery or not? But the problem is there's a big gap in there between those two things where it can be kind of unstable and frying the joint. So a very important thing to do is to make sure your joints don't have any instability. And you wouldn't probably know it, especially if you're younger. A lot of times it doesn't even show up as a problem until you get some age.
Right, and probably a good way to examine that is with ultrasound, because right in the MRI machine you lay still, so
correct.
They're not
So
going to
yeah,
see
it's
that.
got to be a dynamic exam, and ultrasound is good at that.
All right, let me read up here. Andy, let's see. He just had platelet lysate injection 10 days ago. Can you walk me through a bit more what to expect within the next few weeks, months? First few days felt pretty good, and then was really achy days 7 and 8, better the past 2 days. Is that normal?
Yeah, Andy, I'd need to know more about what you had done, what was injected, to know what the course will look like. For example, if you just had a platelet lysate injection epidural, generally that can feel pretty good right out of the gate. But it really takes maybe 2-3 weeks to get maximum results. If you had other things injected like the facet joints, the ligaments, the muscles, then that's something that could take a few weeks beyond that to really show results. So I don't know what you had done.
Yeah, let us know. We'll try to get around that answer better. Randy had PRP with Dr. Kramberg on Tuesday. He was told not to take any anti-inflammatory drugs for 2 weeks prior. He wants to know, can I take natural supplements like Tumeric, MSM, or any supplements that are supposed to help with inflammation?
Excuse me. Yeah, Tumeric would be a good one to take. It works through different pathways, generally the non-steroidal anti-inflammatory drugs, so Tumeric would be a good one to take.
Linda, I'm not sure of this question. What's the success rate of using alpha for arthritis? I know the results are not consistent. Any chance for improvement?
Alpha.
You know what alpha is?
I don't know.
I don't either. Maybe that was a typo. If it was, let us know. Karen is post 7 weeks, post stem cells on the knee, doing good. And then she walked on it a lot. Felt like I went backwards with more stiffness and weakness. Regenexx doc. She just gave me a Synvisc, one injection 10 weeks out, and she had a reaction to that. Low dose steroid. She's about 2.5 weeks out, still limps, using a crutch.
10 weeks out or 2.5 weeks out?
2.5 weeks.
And had a Synvisc injection that caused some reaction?
Yeah. And then the doc gave some low-dose steroid.
Yeah, that's one you probably want to go back to your doc and ask the questions, because there's a lot going on there. I mean, generally, when Synvisc causes a reaction, it can be that some of it got into the prepatellar fat area, and that's where it can cause quite a bit of pain, actually. So I don't know how that injection was done, whether or not there was any injection into that prepatellar fat pad, that kind of stuff.
Harry asks, for an ACL tear, would PRP or stem cell be better at 69 years old?
Yeah, it depends on the extent of the tear. So if it's a partial tear, I would say that PRP might be fine. But given your age, I'd probably go the bone marrow route, just because that's a more powerful treatment for ACL tears than PRP.
Sabine asked, will a cultured stem cell procedure along with a capsular distension potentially heal a double anterior and lateral hip labral tear? 100%. I'm an Olympic rhythmic gymnast and having neck ligament damage, neck implants after major accident, going to the Caymans to see Dr. Schultz.
So we're talking about a hip labral tear or the neck?
It sounds like hip labral tear, also having neck ligament damage.
Oh, okay.
Neck implants. What are neck implants after a major accident?
Maybe an artificial disc that was put into the neck.
Yeah, maybe.
Listen, I think that when it comes to the Cayman procedure and trying to heal things like labral tears, there'd be a high success rate. And then you've got to get into why you have the labral tears in the first place, which is usually instability related if it wasn't, some sort of really big trauma. When it comes to treating neck ligaments, again, that's a good treatment for that. But that's probably something to follow with Dr. Schultz on, since he knows your history.
Yeah. Alpha was A2M.
Oh, A2M, alpha-2 macroglobulin.
Right, exactly.
So the question again was alpha for...
Let me see here. These scroll by and then I can't go back and find them. What was the alpha for? Will you let us know again?
Knee osteoarthritis, I think.
Probably, yeah.
Yeah, so alpha-2 macroglobulin, or A2M, is a molecule that can trap some of the inflammatory molecules in the joint or in the knee joint. And we find that it tends to work better in patients that have quite a bit of inflammation and swelling within the joint, so synovitis. Doesn't work as well in sort of the average knee osteoarthritis patient.
Andy, you asked about the intradiscal injection and some stiffness still. He had bilateral facets and a right L5S1 and right L4-5 TF, transforaminal.
Yeah, so if it's the facets, so again, a couple weeks.
Couple weeks. All right. All right, Randy, you want to ask us some questions? You've got an injection scheduled in 2 weeks. Feel free to do that here. Linda asks again about the alpha-2 macroglobulin. Is not consistent in success. What is the rate of success, and will it improve?
Yeah, it depends on the patient. I think based on what we've seen, PRP and bone marrow concentrate is a lot more reliable. I use A2M in my practice in combination with PRP for patients who really want to try to get some joint protection, which is where I think where the sweet spot is for that type of treatment. So I generally don't use it alone. I'll use it with PRP. And
can you tell us a little bit more about what it is, alpha-2 macroglobulin?
Yeah, it's a naturally occurring molecule that traps inflammatory cytokine molecules in it. So it's got receptors to trap these molecules, so it kind of eats them up. So the inflammatory cytokines are things in your knee that can cause cartilage breakdown. So A2M can trap some of those, and the concept is it reduces or takes out of commission some of those cartilage breakdown molecules. So we tend to use it in patients that are highly focused on protecting their joint cartilage, and usually add it to something else that has anti-inflammatory plus anabolic properties, meaning PRP can ramp up repair. So we'll generally inject A2M with PRP in the knee as an example.
So Linda's asking still a little bit more about this. What about which would be better for arthritis, the A2M or Prolo?
It depends on what it is you're treating. If what you're treating is a knee that has loose ligaments, then Prolo is a good way to go for that. If you're treating just garden variety osteoarthritis, then A2M again plus PRP is usually something we would use.
Randy asks, I've heard the QL muscles, quadratus lumborum, can be a contributor to low back pain. Does the Regenexx low back injections also target those muscles?
Yeah, I mean, certainly if we believe that there's independent tendinopathy in the QL, we can target the QL. I inject it all the time. But it just, obviously that's patient by patient by patient. So we need to be convinced that that QL muscle was involved in the bigger symptom complex, but realize that oftentimes the QL muscle is just kind of a bystander, meaning that the referred pain there can come from other places as well in the spine.
I'm curious for my own info. Does injecting the QL atrophy do anything? The muscle atrophy that occurs?
If you've got muscle atrophy, that I don't know. Yeah.
Because you see that so often. Let's see. Andy. Your connection skipped. Okay. Regarding the I believe, Andy, right, you had the intradiscal, you said you had the facet injections and the transforaminal injections. You had a poor connection to that answer. You remember what we answered about that?
Yeah, it'll be a couple weeks before I think you expect to see improvement.
Awesome. Good. All right. Any other questions? We've got a few more minutes here. I also want to encourage you, if you know somebody who's suffering and looking for a second opinion or a way to avoid surgery, please share this with them so they can find out there's other things available. All right. Any other questions coming in here today? I don't see any. Thanks, Andy. Glad that answered your question. All right, Johnny. If an MRI showed nothing on my knee, but I did the meniscus test where I lay flat on the ground with my knee bent and my foot inward, and there was a sharp pain, what's Regenexx approach on this?
Yeah, well, that's going to require a physical exam to see what's causing your pain. So that could be, for instance, a loose ACL or ALL ligament that's allowing too much tibial rotation and pissing off another structure. That could be a small injury to your meniscus, but less likely. That could be something related to the tendons around the knee. So that's going to require a physical exam. Realize that Regenexx is using a specific diagnosis of what's wrong and then directing this stuff using interventional orthopedics and imaging guidance to the right spot. It's not just putting it in your knee and calling it good. Much more complex than that.
Yeah. All right. Any other questions on this topic? It's an important topic because knee replacement's big, knee meniscus surgeries are big, and there's certainly other options available these days. Any final words?
Yeah. Listen. Happy New Year to everybody, and glad to start doing this again every week. So that we'll be here every week on Monday at 4:30 Mountain Time, 6:30 Eastern Time, 3:30 Pacific Time. And we're here to talk about a topic, but we're also here to answer your questions. So feel free to drop by, and we'll answer your questions.
Yeah, and if you have specific topics you'd like us to focus in on, please put them in these comments, and we will do our best to get to those.
Yeah, or write in and suggest a topic, and we'll be happy to add it in as well.
Great. All right, thanks for stopping by.
Thank you.